Assalamu alaikum, good afternoon, and thank you for joining this session. Today we have an honor that we have great speakers with us. I'll introduce my panel first. We have the chair, Dr. Kausar Bano. She is a medical oncologist, associate professor of medical oncology at Jinnah Hospital, and she is an examiner and a FCPS trainer. And she is actually treating all malignancies, but she has special interest in sarcomas. And with her, we have co-chair Dr. Sameer Fasi. He is our own Shaukat Khanum boy, I would say. He's doing lung, sarcoma, and GI. And he had special training at Canada for 2 years in sarcoma. So that with his arrival, our sarcoma team is strengthened. And then as a panelist, we have Dr. Sajid Mushtaq. He doesn't need any introduction. The most senior and the most compatible and most competent pathologist with regards to sarcoma. We'll start, and I'll request Dr. Kausar to please announce the first speaker.
Assalamu alaikum. Our first speaker for today's sarcoma session is Dr. Joseph Presse. He is working as the director for Young Oncology Group and Young Oncology and Sarcoma Group at the Institute of Cancer and Blood Diseases of Cincinnati Center at Ohio. He's working as a professor at of clinical pediatrics at the same institute. He is also co-director of the Young Oncology Program and Solid Tumor Research Programs. He has also served as principal investigator for the Children's Oncology Group Pediatric Early Phase Clinical Trial Network. And he'll be talking today about precision medicine and sarcoma.
Good morning. I wish to thank the organizers for inviting me to speak today. It is a genuine honor to participate in the symposium. I will discuss opportunities to integrate precision medicine into the care of sarcoma patients. Traditionally, anthracycline therapy has been the mainstay of sarcoma therapy, and it remains so today. Doxorubicin, either as a single agent or in combination with ifosfamide, or in more complex regimens like VDC alternating with IE, remain commonly used today. For osteosarcoma, doxorubicin is combined with cisplatin and alternated with methotrexate as the standard of care. For tumors such as rhabdomyosarcoma, BAC, IVA, or vincristine with irinotecan are considered the standard of care. Gemcitabine with or without taxanes and trabectedin are often used in second and third line therapies. Unfortunately, we've reached a plateau in outcomes using cytotoxic chemotherapy for sarcomas. With maximized dose intensity and optimized supportive care, patients with high-grade tumors that are localized can expect an outcome of 60 to 70%. Those with metastatic high-grade tumors, unfortunately, still fare dismally with outcomes in the 10 to 30% range at 5 years, although the numbers can vary dramatically by histology. Chemoresistance is often present at diagnosis or rapidly acquired thereafter. And that's probably the primary Achilles heel in the treatment of high-grade sarcomas. And this can be acquired through a variety of mechanisms. I would also point out that there are a number of sarcomas that are considered chemoinsensitive at diagnosis. Clear cell sarcoma, malignant peripheral nerve-shaped tumor, and chondrosarcoma would be good examples of such, and are devastating when they are metastatic or unresectable. Major challenge to the study of sarcomas is the rarity and heterogeneity of these tumors. Sarcomas only represent 1 to 2% of cancers in adults, yet comprise 60 to 70 distinct diagnoses, 20 of which are considered ultra rare with an incidence of less than 1 in a million. Panhistology sarcoma studies have generally been relied upon in the past. However, they've been inadequately designed and powered to detect a signal in distinct sarcoma diagnoses. Sarcoma biology is also very heterogeneous. There's a subset of tumors that are translocation associated, such as the Ewing's, alveolar rhabdo, and synovial rearrangements. These are generally genomically non-complex tumors. On the other hand, osteosarcoma, embryonal rhabdomyosarcoma, and dedifferentiated liposarcoma tend to have very complex genomes and are very distinct from the translocation-associated sarcomas. Epigenetically, there's a lot of heterogeneity as well, as can be depicted on the right in the DNA methylation-based clustering of sarcomas. Precision medicine can be defined as the integration of genomic, transcriptomic, epigenetic, and proteomic data, along with immunohistochemistry and ideally PDX modeling. This can be an excellent tool for further aid in diagnosis, assigning risk status, quantifying disease burden, and measuring treatment response. Ideally, precision medicine can also be used to identify therapeutic targets that can be used to exploit molecular vulnerabilities in any particular sarcoma, either in an individual in terms of personalized medicine or in a particular histology. There are a number of studies that have been published in recent years that have reviewed the benefit of genomic sequencing for sarcomas. Italiano and colleagues published in 2016 a study that compared histologic diagnosis rendered by a pathologist and compared it to the diagnosis that was revealed after limited genomic analysis was done. And so this is not next generation sequencing, but using fluorescent in situ hybridization, genomic hybridization, comparative genomic hybridization, quantitative PCR, and RT-PCR, and comparing those results with the histologic diagnosis rendered by the pathologist. Interestingly, out of 384 cases evaluated, 53 had modified diagnoses as a result of the additional genomic work that was done. And so this hinted at the benefit of genomic analysis and at least the diagnosis of sarcomas, which would be critical to providing the best care possible. More recently, Lucchesi and colleagues published in 2018 a study that was used next generation sequencing from the AACR Genie database. 584 patients were included. Among these 584 patients, there were 331 tumors that were considered complex genomes, 144 that were translocation associated, and 112 either simple or no clear alterations were identified. Among these 584 patients, nearly 2,700 genetic alterations were identified in 451 genes. At least one targetable genetic alteration was found in 239 cases, so about 41%. The middle figure depicts the most prevalent genomic alteration, with P53 being the most common, which is not surprising. The figure on the right shows the distribution of the targetable alterations among the 10 most common histiotypes that were studied. Gounder and colleagues published this year an analysis of nearly 7,500 sarcomas. In this study, 10% of the patients had a diagnosis reassignment as a result of this targeted genomic sequencing. 31% of the patients had potentially actionable alterations, but only 3% were kinase rearrangements, which are easily targeted with available therapies. 3.9% of the patients had increased genomic complexity with tumor mutational burden of 10 mutations per megabase. The figure on the right details the actionable mutations among 44 histologies. Similar findings have been found in pediatric and young adult patients with extracranial solid tumors. This multi-institutional study undertaken by Church and colleagues studied 345 patients with a median age of 12 years, although the age range was from birth to 27 years. 298 of the patients, so 86%, had one or more alterations with potential impact on care, whether that was diagnostic, prognostic, or therapeutic. Of the 29 patients who received molecular targeted therapy, 24% had an objective response or experienced some sort of durable clinical benefit. A variety of the patients who received the most benefit were those with rearrangements that had commercially available agents of which to use for targeting. I bring up an example of personalized medicine using next generation sequencing. This is a patient that Dr. Alina Sadov and I took care of here in Cincinnati, who I think is an excellent example of a patient who benefited from more sophisticated genomic analysis. This was a healthy 23-year-old who presented with a lower extremity mass. The diagnosis really revealed a low-grade sarcoma, not otherwise specified, and with a spindle cell histology. Upon further staging, however, it was found this patient had widely metastatic disease with nodal disease and lung metastases. Targeted next-generation sequencing of the primary mass and one of the metastatic lesions revealed no diagnostic or therapeutic targets. However, whole exome transcriptome next-generation sequencing revealed a novel RGAP23 FIR oncogenic fusion. FIR is a tyrosine kinase, and we found that it was targetable with a tyrosine kinase lorlatinib that is generally used for ALK-ROS mutations. And this patient was started on therapy and experienced a dramatic effect with a metabolic effect depicted in the middle, with PET scan showing a dramatic decrease in metabolic activity in both the primary lesion as well as the metastatic lesions. And the middle figure depicts from the time of start of therapy to 10 months in. The MRI on the right reveals the effect over the first 20 months of therapy. And I can now update that this patient has been on therapy for 28 months and continues to receive benefit with even further decrease in metabolic activity in all the lesions, some of which are no longer detectable. She's tolerated lorlatinib well and continues on with graduate school. So this would be a great example of a patient who benefited from fairly sophisticated whole exome transcriptome analysis and would be sort of an ideal example of personalized medicine in the sarcoma field. Next, I'm going to move on to targeted therapies that have been established for specific histiotypes. So gastrointestinal stromal tumors would probably be the best example and the longest standing example of targeted therapy for sarcomas. Imatinib has been studied for over 2 decades now in GIST tumors and has been found to be of benefit. As is known by this group, adult GIST tumors generally carry either KIT or PDGFR alpha mutations that are targetable. Other TKIs beyond imatinib have also been studied in GIST and found to be of benefit. We also recognize that there are subsets of GIST tumors that don't carry KIT or PDGFR alpha mutations. The pediatric GIST are well known to have SDH mutations, but also NF1, BRAF, and NTRK have also been found, some of which have been targetable with precision therapies. There's a considerable literature describing the effects of TKIs in GIST tumors. This particular study published in JAMA Oncology in 2020 is a nice example of the benefit of imatinib in GIST tumors. This study was conducted in Scandinavia and Germany. Patients were randomized to receive 1 versus 3 years of imatinib therapy after optimal surgical resection. These were patients that were thought to be at high risk of recurrence after surgery. The analysis concluded that approximately 50% of deaths may be avoided during the first 10 years of follow-up after surgery with the longer 3-year treatment of imatinib. We also recognize that imatinib is generally well tolerated and has been an easy choice for such patients. Another group of tumors that have been studied for response to precision medicine include the SWI/SNP altered tumors. So these are tumors generally that have either SMARCB1 or SMARCA4 mutations. Epizyme has studied in their trials EZH102 for pediatrics and 202 for adults, the benefit of tazemetostat, an EZH2 inhibitor in select tumor types. EZH2 is an enzyme that is upregulated in the setting of SWI/SNP alterations. In that situation, polycomb targets are repressed and it leads to oncogenic transformation downstream. And so EZH2 inhibition has been thought to be an advantageous way of inhibiting that process in affected tumors. The biggest signal thus far has been seen in epithelioid sarcomas. Cohort 5 of the EZH202 trial focused on ES tumors. 62 patients were enrolled on this cohort, 15% of which experienced objective responses, 26 with disease control at 32 weeks, and median progression-free survival was 5.5 months. Subsequently, the FDA approved tazemetostat for ES tumors, and this is now commercially available here in the US. Another major success in targeted therapy for sarcomas and other related tumors has been with larotrectinib for tumors with TRK fusion. This is a study that was published in 2018. It was a combined phase 1-2 study for both children and adults. 55 patients were enrolled. Ages range from 4 months to 76 years. And there were 17 unique TRK fusions included in the cohort. The overall response rate was 75%. At 12 months, 55% of patients remained progression-free. Of note, at 9 months, 86% of the patients with a response were still on therapy or had undergone subsequent surgical resection of any residual mass. Larotrectinib is now also approved and commercially available and is considered standard of care for infantile fibrosarcomas that generally carry TRK rearrangements, as do mesoblastic nephromas and a variety of other tumors that may not be predictable based on histology alone. Going back to imatinib, it has also been studied in locally advanced or metastatic tenosynovial giant cell tumor, also known as pigmented villonodular synovitis. This is generally thought of as a benign neoplasm of the synovium, but it can be very aggressive. These tumors generally overexpress CSF1 and have shown responses to imatinib, and imatinib is now considered a standard of care when these tumors cannot be amenable to resection alone. More recently, a more targeted agent, pexidartinib, which has a specific targeting of CSF1, has also been studied in PBNS and found to be of benefit. I do note, however, there is a black box warning for risk of hepatic toxicity with this agent, but it is also effective and has been shown to be so through a placebo-controlled trial. Dermatosarcoma protuberans is a rare cutaneous sarcoma that is also amenable to imatinib. These tumors are characterized by collagen PDGFR alpha fusion. Surgical resection is standard of care, but in the case of unresectability or metastasis, medical therapy is sought, and imatinib has been shown to be effective, mostly through small studies and anecdotes. I recognize this is a bit of a busy table, but to summarize the findings, the median treatment duration on this particular study was 3.1 months. The median tumor shrinkage was 31%, with the best overall response in 7% of the patients being complete response. 50% of the patients had partial responses and 35% stable disease. Only 7% had progressive disease. The picture on the right depicts an obviously very aggressive case of DFSP. But it is interesting to show the effect of imatinib in this gentleman with a fairly dramatic response. However, the arrows in the bottom picture depict some areas of resistance and growth and show that it is not without the potential for resistance. And so other novel or targeted ways of approaching these tumors are in need. But patients have generally responded, and again, this is a very tolerable agent. Pazopanib has also been very well studied in soft tissue sarcomas. The palette study was a study of patients with metastatic soft tissue sarcomas who had progressed despite standard chemotherapy. The study was a randomized 2-to-1 placebo versus pazopanib. And the median progression-free survival on pazopanib was 4.6 months versus 1.6 on the placebo. Pazopanib is now also FDA approved here in the US and is commercially available and often used for, in this particular setting, in patients who have either failed chemotherapy or in select subtypes of sarcomas in which chemotherapy is known not to be effective and for where there is a track record for pazopanib. The study on the right is a long-term study that shows that there are a subset of patients with soft tissue sarcomas who have prolonged responses. In this case, 3.5% of the patients on the study by Casper and colleagues showed a durable effect of pazopanib beyond up to 2 years and beyond. And this has been seen in select diagnoses, usually in low to intermediate grade sarcomas that are also potentially metastatic. Finally, I wanted to discuss osteosarcoma. This is a particularly challenging sarcoma. It peaks in incidence in adolescence, but it extends well into young adulthood. There's also a peak in later adulthood as well. These are genomically very complex tumors with many non-recurrent translocations identified, as well as whole chromosome gains and losses and copy number changes. Compared to other pediatric cancers, especially compared to leukemia and even other, and to translocation-associated sarcomas, the genomic complexity is immense. And there's been very little innovation after the introduction of multi-agent chemotherapy in the late 70s. The Kaplan-Meier curve in the bottom right depicts combined data from 7 Children's Oncology Group phase 2 studies of osteosarcoma. The conclusion of this combination data was that progression-free survival at 4 months in all these studies combined was only 12%. And this has set a new bar for new studies and in terms of comparison and what would be considered success moving forward. There have been a couple studies recently that have focused on VEGF targeting tyrosine kinase inhibitors for osteosarcoma. A placebo-controlled study of regorafenib was undertaken by the SARC consortium, and regorafenib was found to be superior to placebo, with a median progression-free survival of 3.5 months versus 1.7 for placebo. This data was encouraging enough that now regorafenib is being combined with an immune checkpoint inhibitor in the new SARC study, SARC 038. And a similar drug, cabozantinib, will be used in a high-risk osteosarcoma phase 3 study, also to be conducted by the Children's Oncology Group. On the right, the OLLI study combined lenvatinib with chemotherapy, so another VEGF targeting TKI, and found that there was benefit too, with progression-free survival at 4 months being 51%. And so this is also an encouraging study and demonstrated the ability to combine a targeted agent with chemotherapy, which ultimately will be of benefit to our patients with such aggressive tumors. Quickly, I wanted to mention a few studies that I think are very encouraging and we'll be awaiting new data from that are using targeted therapies with or without chemotherapy backbones. The gemcitabine plus ZNC3 incorporates the WEE1 inhibitor being produced by Zentalis, and this is ongoing. We have it open here at Cincinnati Children's. CDK4/6 inhibitor palbociclib is being combined with topotecan and cyclophosphamide in a Children's Oncology Group trial. Tegavivent is a phase 1 study currently being conducted by the Children's Oncology Group. This is a small molecule inhibitor of Wnt pathway with particular interest for Ewing sarcoma and osteosarcoma, as well as desmoid tumors. CBL0137 is a FACT inhibitor with some very encouraging preclinical data in osteosarcoma. And finally, I wanted to also mention radiopharmaceuticals that are garnering more attention. CLR131 is a lipid raft targeted agent that is conjugated to iodine-131. And this is being studied in pediatric solid tumors and CNS tumors as well. I'd like to thank you for your attention, and I look forward to a very interesting discussion. Thank you.
So thank you, Dr. Joseph. It was a very good talk. It would have been great if Dr. Joseph would have joined us in person. I think we can take the question answers in the end. So we will move to the second of the presentation for today by Dr. Erna Nixon. She is a consultant clinical oncologist and visiting professor at Wheatson West of Scotland Centre. She's a clinical lead of Sarcoma Centre Scotland.
Hello,
and a
everyone.
special
Thank you.
interest in soft tissue sarcomas,
There is a quote
bone sarcomas, and
when
GIST.
me and my best friend.
In addition, she is a regional quality improvement lead and a center innovation lead as well. The title of the talk would be The Value of Clinical Networks in Sarcoma, Care Experience from Scottish Sarcoma Network.
For this so kind invite. There is a quote from Hippocrates that says, when me and my best friend are watching this movie, I don't know if any of you have seen this. Now it's the Groundhog Day. Now you may think that movie is a comedy, so all cheery. However, that wasn't the case. My friend was about to start chemotherapy for a rare bone cancer. In fact, he was due to be admitted for chemotherapy on the next day. I then knew very little, if at all anything, about bone cancers. Seeing healthcare through the eyes of my friend, as a carer, being on the receiving end of care was an eye-opener for me and influenced the way I view care and my decision to become a doctor. This experience showed me people with a rare cancer like a sarcoma require a lot of support, which should be tailored to their unique needs through the journey from diagnosis through treatment, follow-up, and survivorship. When we think about sarcomas, all of us treating this disease, there are two things that cross our minds: rarity and diversity. Sarcomas are rare and diverse. They can happen in any anatomical part of the body and at any age group, reflecting on how needs of patients can differ. They ought to be treated by teams with expertise, ought to be treated in specialized centers, ought to be managed by an MDT in a clinical network, which works in partnership with wider networks, clinical and non-clinical. We talk about clinical networks, but what is the definition of these? They are linked groups of health professionals and organizations from primary, secondary to tertiary care, working in a coordinated manner, unconstrained by existing professional and health board boundaries, and that to ensure equitable provision of high quality, effective services. So we say clinical networks are important, aren't we? But is there any evidence? Some examples from the French sarcoma group. We know there is a significant impact on local relapse-free survival and relapse-free survival when patients are being discussed at a specialized multidisciplinary team forum, part of a wider network prior to first treatment. We also know that when surgery is performed in a reference center, there is a significant impact on survival. When patients are operated in reference centers, there are fewer reoperations and higher rates of R0 surgery. And that also improves outcomes, namely improves survival when surgery is performed in reference centers, part of a network. Moving on to research, a known study to all, doxorubicin alone versus doxorubicin plus ifosfamide for first-line treatment of advanced or metastatic soft tissue sarcoma. This is a randomized controlled phase 3 trial. 38 hospitals participated in 10 countries from April 2003 to May 2010. And 228 patients were recruited. The GETIS study, where 257 patients were recruited through 24 UK hospitals and 1 SAC hospital. And more studies that we wouldn't be in the position to conduct unless we worked closely together. So we have seen evidence on how clinical networks can improve care for patients with sarcomas, which now brings my focus nicely to all of us here today on a question to ask ourselves. How do we value networks? What is the value of networks in rare diseases? What does really matter? So to address this question, I reached out to my diverse global network, including colleagues, patients, carers, academics, charities, and here is what they have said. Networks are vital to the study of rare cancers and have markedly changed clinical practice. United, together, we can learn more about this rare and diverse disease, and we stand better chances of giving a better response to our patients than we just don't know enough about this to guide decision-making. We need close and trustful international collaboration to improve care for patients, and that can only happen through networks. These are diverse and are clinical and non-clinical. Through networks, we can offer patients peer support, and we can also gain a better understanding of their unique complex needs. We can understand the disease better. Networks are fundamental for personalized and realistic medicine to be realized through shared learning, research, and clinical innovation. From clinical networks starting from a local multidisciplinary team discussing optimal management to wider clinical and non-clinical networks, all are important to patient care according to patients. Compassion is also mentioned as a core value of healthcare professionals and as one of the networks aiming to optimize care for patients. In very simple words, networks connect, and this is not just valuable, but essential to patient care, especially in rare diseases such as sarcomas. All comments shared by my sarcoma community are so rich, thoughtful, and thought-provoking. Networks are valued, but it is also the values of networks that make them more effective in driving patient care forward, which has been more than ever evident during the pandemic, when we collectively had to reach out to each other, work with other networks, share learning, and do the best for our patients. We're now over 2 years into the pandemic, and the climate in healthcare in the UK is rapidly changing. Scotland is no exception. There's a word for it coined many years ago by the military, and this is VUCA. And in many respects, VUCA is the new normal. And in this climate, the urgency for change is the driver for more collaborative work, building more bridges between existing networks. Which nicely allows me to introduce you to the Scottish Sarcoma Network, a network I know well, as I have been the clinical lead since 2015. The Scottish Sarcoma Network is the clinical managed network in Scotland aiming to ensure equitable, safe, evidence-based, person-centered and timely care for every sarcoma patient in Scotland. A bit about us and the service. In Scotland, surgery for adult sarcomas takes place in 3 sites, in Glasgow, Edinburgh and Aberdeen. Surgery for pediatric and adolescents takes place in Glasgow and Edinburgh, whereas oncological treatments such as radiotherapy and SACT treatment is provided in 5 sites: Glasgow, Edinburgh, Dundee, Aberdeen and Inverness. We have a National Sarcoma MDT, which is a weekly multidisciplinary team meeting where all sarcoma cases are referred and discussed for optimal management. It will be interesting to see what we as a network have been doing in the calm when we were not dealing with the pandemic, and also look at what we have been doing during the pandemic and share some reflections and learning with you. So in the calm, the network has enabled a number of developments important to patient care. And an example I would like to share with you is on early diagnosis through the development of the MSK referral pathway. So you will hear from my colleague, Mr. Ashish Mahendra, on this development.
I'm Ashish Mahendra. I'm an orthopedic oncologist at Glasgow Royal Infirmary and have been part of the Scottish Sarcoma Managed Clinical Network since 2007. Early diagnosis is the cornerstone of sarcoma management. And delay or inappropriate intervention can lead to significant ramifications to patient outcomes. In 2010, due to increasing demand on the west of Scotland MSK.
The Scottish Sarcoma Network also drove the development of a national sarcoma research strategy in 2019, which was not existing before, to enhance research opportunities for sarcomas in Scotland, fostering collaboration with other research networks. Here you see the Beaton Cancer Centre, where I'm based, which is a CRUK centre with a renowned CTU and a rich portfolio of clinical trials. I have many examples of collaborative work through the network in quality improvement research and clinical innovations. The list is huge, and somewhat when we talk about these developments, we make things sound too simple and straightforward, don't we? Nevertheless, things look pretty different in reality. This is Janus, the Roman god. He's very unique in that he has 2 heads, one with eyes facing forward and one facing backwards. He's the god of transitions, and January is named after Janus. What we can keep from Janus in the Scottish Sarcoma Network and as a sarcoma community and in healthcare is we need to look backwards at the processes and structures that we have and how we can make this more efficient, effective, cost-effective and safe, while simultaneously facing forward, thinking of the innovations that we need to essentially disrupt current processes to take us where we need to go. We need quality to be the base in healthcare in everything we do. We also need to take it to the next level, which is innovation. And this is where the Scottish Sarcoma Network plays a key role on strategic and operational delivery, ensuring equitable, safe, best, efficient, evidence-based, timely, and person-centered care for sarcoma patients. This is challenging, as change is always challenging. However, during the pandemic, the urgency for change was the first driver for innovation in the Scottish Sarcoma Network. How? What is our approach to change? Our approach is shifted from the typical approach where all is decided and designed in the conference room before implementation to a quality improvement approach which enables change. And the National MDT Improvement Project that led to us being nominated for the BMJ Awards in 2020 is an example of this approach. Speaking about change, the pandemic forced several changes upon us. We had to respond to these changes rapidly. to sustain services and more. In response to the pandemic, we have developed sarcoma radiotherapy guidelines in line with RCR, the Royal College of Radiologists' recommendations. We also developed sarcoma SACT guidelines, sharing some data over the period of 22 months from first lockdown onwards. The total number of patients discussed at the MDT was 1,651, out of which 817 cases were new cases. The number of cases we recorded that were impacted by COVID was 7, 3 new patients and 4 return patients. We also changed the ways we work with the implementation of telemedicine. We collectively did a project to assess patient and professional views on the impact of telemedicine for sarcomas. This was in collaboration with Robin Jones's team at the Marsden and the University of Strathclyde. What we found was that experience of both patients and providers were broadly positive, with patients and providers being receptive to the long-term implementation of telemedicine. There's no one-size-fits-all approach, though. We now move to phase 2, doing in-depth, semi-structured interviews to better understand how telemedicine should shape based on patients' needs. During the pandemic, we also started using My Clinical Outcomes platform for remote monitoring of patients with GISTs. We are still collecting data and hopefully we'll be able to share soon. Very importantly, on the research front, obviously during the pandemic, COVID studies took priority, but we're delighted that Glasgow and Edinburgh are part of the Sarcoma Accelerator Consortium, a 5-year project aiming to provide a digital hub of clinical and research data on sarcomas, as well as cellular and animal models. This to help us predict and test patient responses to drugs for high-risk sarcomas using artificial intelligence. As a network, we are devoted to personalized care, and we use the What Matters to You tool for every inpatient. We know that it takes only 90 seconds for a patient to tell us what is most important to them. This tool applies not only to patients, but to our colleagues too. Even more important during the pandemic, with VUCA being the new norm. To bring you all into my world, I asked one of my patients, Roisin, to share her experience of being treated during COVID with us.
Skip this. We can finish with that.
Hi, Roisin. It's
Hi.
So, I find it always very inspirational listening to patients, and I always learn new things through the interaction. As for key learnings on challenges and positive change, here is what the wider sarcoma community has said. In summary, telemedicine enabled us to consult patients remotely, but we would not put a hand on the shoulder or hug a patient when we need it. The pandemic allowed us to reevaluate and structure how we practice medicine through partnership with patients. Only if we look at caring as a team sport, we can support patients the most. And here you see, let's call her Mary, a 16-year-old patient of mine who had an osteosarcoma treated in the context of Eurowings protocol. And it's incredible. She can now walk. Closing, in this slide, you see a snapshot of a Zoom meeting, very popular these days. What is special about this meeting is it is uniting patients, clinicians, and the health minister in a virtual celebration of the completion of the first panel of the Cancer Tapestry. The Cancer Tapestry was born during the RISE event in 2018, an event on resilience for sarcoma patients and carers in Scotland. In that event, Andrew Crammy, who is a former cancer patient of mine and an artist, shared the idea of creating a tapestry on cancer with other patients. The support was extraordinary, and this project started joining hundreds of patients, families, health professionals, telling their stories stitch by stitch. Here you see Heather, former patient and lead stitcher for the first panel of the Cancer Tapestry, who is adding in this ceremony the final stitch. Heather, on that day, which was during the first lockdown, spoke about her cancer journey and also expressed her support to all patients undergoing treatment during the pandemic and lockdown. And her story reminded all of us that at the heart of all healthcare are people, people with hopes, fears, and every one of them matters. I will leave you with the words of my friend. At the end of the day, like in the movie, spring will come. We are moving forward. Despite adversity, we innovate. And we have proved that in partnership through our clinical and non-clinical networks, we can improve care for our patients like the Symposium. Because as Hippocrates says, if there is a love of medicine, let us shine this love in our professional lives, teams, and networks. Thank you very much for listening.
Thank you, Dr. Nixon, for a very comprehensive talk on the value of clinical network in sarcoma. Really, the clinical network is very important, not only to improve the quality of life, but also the survival of these patients. So moving forward with the session, our next speaker is Dr. Ahmed Shoaib. Dr. Ahmed Shoaib is currently working as a medical director and head of orthopedics department at Indus Hospital, Lahore. He's also an examiner at the Royal College of Surgeons, Edinburgh, and he did his graduation from the Allama Iqbal Medical College in 2002, and after that he got his training at the University of Yorkshire and did his FRCS in trauma and orthopedic surgery. Later on, he has worked at very prestigious institutes, and after working abroad, he came back to Pakistan and worked as consultant orthopedics, first at the Shaukat Khanum, now he's working at the Indus Hospital. He'll be talking about the orthopedic sarcoma surgery updates.
Thank you very much for inviting me. It's nice to see my previous colleagues, and I hope you can hear me okay. So my presentation is basically geared towards people who are non-orthopedic surgeons, because I thought that there would be very few orthopedic surgeons sitting over here. So I'm going to follow the patient pathway, what challenges we face as orthopedic surgeons and treating physicians for these difficult cases, and how the latest evidence which has emerged over the last 1 year help us in making those decisions, and what are the new upcoming surgical technologies. So we have a unique challenge. The patients are often presenting late to our clinics. The average size presenting in the West is about 9 centimeter. And for us, it's 18.5 centimeter, according to an audit done by Dr. Zishan Khan in Peshawar. And we know size matter in sarcoma or cancer surgery. Often patients present with history of trauma. The literature says about 30%, but if we ask our patients, vast majority will relate it to some kind of trauma. Still, there is no evidence that trauma has any role with sarcoma. So what is the challenge? You can see over here that lady had a biopsy done of her knee. So the biopsy is often done by non-orthopedic surgeons, by general surgeons usually over here, because of lack of network, which we were discussing. It is in the wrong area, wrong size, in the correct patient usually. So this gives us a very big challenge of, because we're going to go on the medial side, and this patient has already got the whole of the lateral side contaminated by the biopsy person. And we are working hard nowadays in order to improve this. Core needle biopsy is the gold standard. Ultrasound guidance, systematic review published last year, a couple of years ago actually, showed that this gives very good sensitivity, safe, very little complication, and rarely requires repetition. The second paper which came out this year is extremely important for people like myself and Dr. Ilyas Rafi, because the previous patient had a large incision or the surgery done from the lateral side for a biopsy. And sometimes it's impossible to save the leg by approaching the medial side and not excising the other side. So essentially, you have to excise the scar in order to achieve a complete control. But this is frequently difficult in our setup because trauma surgery in orthopedics is all done through lateral side of the knee. And that's where the surgeons are trained. They just approach through the lateral side, making our surgery, which is through the medial side, extremely challenging and difficult. So this paper essentially showed that there is some evidence that it's not very strong, but if we leave that scar alone, which in fact me and Dr. Ilyas both have done in the past, because otherwise you can't save the leg, can be safe. Then there is this million-dollar question about the indeterminate nodule. I think this is the best paper which came out in the last 1 year. This paper from Birmingham, Professor Leajes is also one of the senior authors, and they showed that these sub-centimeter nodules are actually tumors in most situations. So this is a osteosarcoma at presentation, sub-centimeter nodule, 3.6 months, and then 5.5 months. When we are sitting in the MDTs, we know that there is something not right about it, but that's what the definition is, and that's what we have followed over the years. So this paper actually shows that 73% of these intermediate, indeterminate pulmonary nodules progress to metastatic lesions at a median time of 5.3 months. And also, the 2-year survival is much less in these patients when compared to those who are presenting without nodules. For me personally, this is one of the paper which changes practice, and I'll come in and explain it in the next slide how it has changed. And 86% had disease progression at 2 years. These are very significant findings. So the patient has had the biopsy, has gone through the MDT, and now it has come to our table for surgical planning. This is the patient. So we have got two options. We can either do limb salvage using patient's own bone, which is frozen, irradiated, various other methods. And if you can see, patient has got their own knee in there. So the literature says that if you preserve own joints, then the longevity of the implant, if it's all heals up, is like lifetime. That you don't have to revise or redo surgery, and that's why it used to be the preferred method. The other option we have is to do this type of surgery, a megaprosthesis, which is technically demanding. It is expensive, which is relevant to our setup. But the patient walks the next day, send them home in 3-4 days time, remove the clips in 2 weeks, and they are up and running afterwards. So we are going to, over the last few months and last couple of years since I was in Shaukat Khanum, there was a clear shift. Both me and Dr. Ilyas were doing more and more of these megaprostheses because we could see the difference. And when I had a chat with Professor Leajes, and he said, well, we are moving away from the reconstruction business, and we are sticking to the megaprosthesis, which is a distal femur replacement. You can see in this picture. So this is the number of limb salvages in Shaukat Khanum, and we can clearly see the trend that from 2017, 18, 19 onwards, the limb saving procedures dramatically increased, and vast majority of those were megaprosthesis or distal femurs or proximal tibias. We don't have allograft available in this country. It is used in the West, especially in children. We have to use patient's own autograft after freezing it in Shaukat Khanum. We were using it, and that takes a long time for it to heal. On the other hand, this young girl, I think she was 12 or 13, had a distal femur replacement, and to be honest, I don't remember seeing her, and she's still surviving. But because the outcome is so good, you don't see them as surgeons. So we knew that this was happening. We collected the data, and Dr. Bilal is here. He was the author, and he published our data. It was published actually this month's Journal of Pakistan Orthopedic Association, which shows better results with megaprosthesis. So if we have got somebody who has an intermediate pulmonary nodule, I would go more towards megaprosthesis, mobilize them, walk them, maintain quality of life rather than thinking about 5-10 years, knowing that they have got a poorer outcome and you're likely to achieve better results with the megaprosthesis. And that's how that paper has made a difference to our practice. As far as irresectable pelvic tumors are concerned, me and Dr. Samir used to have a lot of discussions about these patients. There is no good option. This was a case done by myself and Dr. Ilyas Rafi together. We did that pelvic resection. So if you are unable to achieve this resection, there is still no good option available. And there is a very high risk of complications, and this paper from Japan showed that nearly 1/3 developed AVN, which is a crippling problem, and nearly half got pelvic fractures after radiotherapy. Coming to the telescopic vascular fibula technique, we started that about 2 years ago in Shaukat Khanum. And the reason behind that was if we are doing this much resection, which is about 20 centimeter, the frozen autograft was simply not working very well. So we thought that if we put a vascular fibula telescoped into the autograft, you have got a live bone within the dead bone, and that might improve things. So this is a vascular fibula graft, which we were inserting inside. This paper published again in 2021 last year showed that there is no significant difference. It can be used, but the difference was not significant as far as outcome is concerned. I think for us, it's important because in the West, they do not mention in this paper about the size. We are asking too much from the surgeon as well as the patient's bone due to the size of the tumor we are facing. So I still believe that slotting in a vascular fibula inside the host bone is probably a good idea. As far as newer techniques are concerned, this X-ray from one of my patients shows that the bone has on-grown onto the prosthesis. So it has basically involved the prosthesis. This will probably last forever, as long as the patient lives at least. There are very good results. So I think this should be used as much as possible, where we can use hydroxyapatite coated implants, which are now available, and we are using them more and more. So you can see over here, the bone has just grown on top of the implant because the colored area of the implant has got a hydroxyapatite coat. Then this is a patient of mine, which I handed over to Dr. Ilyas, who did a 3D printed prosthesis. This is the new thing which is coming up. This paper, sorry, there is a paper published, I forgot to put its details in there, showed 80 of these patients, retrospective case series published in JBGS American, which is the highest impact journal, showed that there are good results after pelvic resection with custom-made 3D printed prosthesis. I think cost will be an issue over here in Pakistan, but ultimately, once the Chinese start sending us these implants, I think we'll be doing more and more of these in future. Thank you very much.
Thank you, Dr. Shoaib. It was a very good talk. So we will move to our next presenter, who is Dr. Hassan Hamid. I personally know Dr. Hassan Hamid from my training when I was in internal medicine, Shaukat Khanum. Besides being a lovely colleague, he's also has special interest in HER2-positive breast cancer and synovial sarcoma. Currently, he is working as a consultant medical oncologist at the Christie National NHS Foundation Trust, Manchester. He gained experience as a specialist registrar at Beats and West of Scotland Cancer Centre, Glasgow, and as a consultant at Mid Yorkshire Trust. Additionally, Dr. Hamid has research experience gained from working as a research fellow in germ cell cancer, germ cell tumors at the Royal Marsden Hospital, UK. And he's going to talk, the topic of the talk is synovial sarcoma and changing paradigm. Over to you, Dr. Hamid. Thank you.
Thanks, Samir, for your kind words. It's always a pleasure to come back to Khanum Cancer Hospital. And I would love to say that I have my roots embedded here. So, as Samir said, I work at the Christie Hospital, and my special interest remains in sarcoma spectrum. So just briefly, I would like to introduce that sarcomas are rare cancers, and talk about synovial sarcoma today. And I will take a few opportunity to talk about its epidemiology, current treatment paradigms, and then we look at the immune biology and also where the cell therapies are coming up in this work. So soft tissue sarcomas are rare mesenchymal tumors. They can arise anywhere from head to toe, as we have heard from our surgical colleagues that they have a predominance to limbs, but they can come anywhere. Synovial sarcomas are rare. CRUK tells us that incidence is 1.4 cases per million per year in UK. The median age is around 30, but we do see cases at the extremes as well in the young age and also in the old age as well. The typical presentation is with the soft tissue masses in the extremities, how they can happen in pleura, retroperitoneum, and head and neck. From the pathology perspective, although the name is synovial, but they don't arise from the synovial surfaces. They are soft tissue malignancies of uncertain tissue of origin. Typically, they are spindle cell tumors with variable epithelioid component, monophasic, biphasic. Technically, they're regarded as high-grade disease. Majority of these presents as an early localized disease. However, we experience that 1/4 have a de novo metastatic presentation. And the median survival is only 16 months in advanced disease. But the 5-year survival is still 25%, which will come back into later. The current treatment for localized disease is always surgical colleagues with surgical resection with either consideration of pre or post-op radiotherapy. Chemotherapy with either neoadjuvant intent is a subject of debate in sarcoma oncology. Coming back to the advanced disease, unfortunately, those synovial sarcomas are classified as a chemosensitive disease, but still the response rates from the standard chemotherapies are very modest, with the anthracyclines ranging from 20 to 25% response rates with median PFS of 6 months. Second line setting with trabectedin in the response rate in the order of 5 to 20%. So this gives us a sense that this is a disease with unmet need, with advanced disease biology, and unfortunately limited prognosis. So I will take a slight change of subject here. I will take you to the molecular pathology of synovial sarcomas. We all know that with the TX18 translocation, it just disrupts the BAF complex, and which lead to chromatin remodeling, transcriptional dysregulation, and stem cell-less behavior. And this may lead to upregulation or re-expression of certain proteins, and which are the one which I will talk now in a bit more detail, and these are called cancer testis antigens. So they are got upregulated with the BAF complex disruption, and the novelty of these antigens is that they are present only in the cancer cells, absent in the normal cells, except the testis gonads. A couple of one with discovery of cancer testis antigens lead to a couple of discoveries of NYSO antigen, which is expressed nearly in 76% in synovial sarcomas. Second one is MEG3A4. As the table tell you that it is expressed in other cancers as well, but in synovial sarcoma, the expression is nearly up to 60%. So the concept relies around that if we can target these antigens with cell therapies or with some treatment, then we can provoke an anti-cancer immune response remissions. This is where the concept of adaptive cell therapy arises. Now talking about these targeting these tumor antigens, so we have flurry of antigens which are expressed on the cancer cells, and at the same time a non-essential normal tissue, which is like CD19, and which is the proof of concept of the CAR T therapies, where we target the CD19 antibody with the CAR cells. The second one is the antigen which are overexpressed on cancer cells, but at the same time they're overexpressed in normal tissue as well. Like the classic concept is the HER2 treatments. And this is where the problem arises when you target these antigen with the treatment. The side effects arise in the normal tissue as well from the treatment. Third one is the one which is expressed only in the cancer cells, like the cancer antigen. And they become more lucrative because if you target them, you don't have off-target side effects, because so you're only targeting the cancer cells and you don't expect any toxicity to happen in the normal tissue as a result of that. Other prospects remain viral antigens and also of the VEGF from the tumor. So how can we target these antigens? So the concept remains of either taking the natural T cells, which can be either isolated from the tumor itself, which are tumor-infiltrated lymphocytes, or we can genetically engineer T cells from the blood lymphocytes, which are TCR and the CAR, which is chimeric antibody receptors. I will take a moment here and show you what's the difference between a CAR T and a TCR as well. So the CAR T therapies are, so these are the T cells which are engineered. However, they can only bind to the extracellular domain of any cancer cells. As a result, it limits the options. Normally, the antigens on the cancer cells are only in 10% in the extracellular domain only. So you need a treatment which have both intracellular domain and extracellular domain access as well. And the TCR provides that dual lecture. But at the same time, the TCR require an integration with the HLA matching and MHC expression. So TCR only works when they bind to the HLA complex. So this is a limiting factor here. The TCR looks good with accessibility, with higher expansion to different cancer types, but it requires this interaction so that the anti-cancer impact can be seen. Now I'll take a little bit of time from you as well, that now how these adaptive cell therapies work. So the process starts from the patient that we take the T cells are freezed and they are collected from the patient, and then they are exposed to a vector virus. The job of the vector virus is that it already has the DNA, which is encoded to that antigen that we want to target, and that vector virus integrate that DNA into the chromosome of these T cells. So these become now genetically modified, and they're meant to produce those receptors which are required to target the cancer. Now, once we have done this, the next thing is to make an expansion. And during this expansion process, the whole time required from this process to this process is nearly 6 to 12 weeks. And this is a limiting factor in how we can safely deliver these treatments. So once we have gone through the expansion process, the cells are ready to be infused back to the patient. Now we need to give these patients some conditioning chemotherapy so that we can dampen the immune system. Because once we want these genetically modified T cells to get embedded into the patient or to progress or to relish, we need to deplete their immune system. So patient has to go through some conditioning chemotherapy prior to receiving this adaptive cell therapy treatment. So in nutshell, the patient have to experience toxicities from the cell therapy, but also have to go through the conditioning chemotherapy prior to that as well. Now, I think going into what's the evidence behind it. So going back before, I was saying earlier on that CAR cell therapies are currently have a standard of care in hematological malignancies, and there's a proof of concept already exists. So GSK made the first antibody for engineered TCR antibody against the NYSO. And from 2018 and 2021, we can see that they have run trials in different disease groups, including non-small cell lung cancer, multiple myelomas, and sarcomas as well. And in there, they received the FDA breakthrough status a couple of years ago in synovial sarcoma. And this is based on the concept that although the numbers are very small, but here there were 12 patients in the synovial sarcoma group, 50% responded, and with one having a complete response and 5 having a partial response. The median overall survival was nearly 24 months as compared to 12 months for those who were non-responders. Median POR was nearly 7.1 months. Median overall survival was 24 months in this cohort. Regarding the toxicity profile, there was bone marrow suppression, as you can imagine, pancytopenia, cytokine release syndrome with these treatments, Guillain-Barré syndrome, graft versus host disease, and there's a concept of ICANS syndrome, which can happen from, although this is something which is a subject of debate because the most of the data of this is from the lymphoma patients rather than from the sarcoma patients. This year in ASCO, we have the second publication from the MSL. So MSL is the genetically modified T-cell receptor against the MAGE-3 antibody treatment. And so they published patients, data from 79 patients. Of them, 65 were synovial sarcoma, 14 were MRCLS. And again, inclusion criteria was HLA-A2 allele along with the MEC positivity. And again, the response rates in synovial sarcoma was really 40%, 2 complete responses, 22 partial responses, and median duration of response was nearly 52 weeks. Median PFS was 18 weeks. So we can all see that there is a signal here that these treatments have an activity. I'd like to conclude here now that we all believe that TCR gene modified cells are an exciting advancement for synovial sarcoma. Durable remissions are being seen in patients who have refractory metastatic disease. These treatments are complex and they have physiological toxicities, financial toxicities, and HLA restriction is a catch here as well. And very interestingly, the HLA, when we did in the MAGE-3 trial in the USA, the HLA-A2, the one which we have the match now, it was found to be quite low in South Asian population. And licensing applications are ongoing. And I think we have to be the space, watch the space here. And I think the oncology community have to start thinking ahead of ourselves to see when these treatments in the near future will come to the standard of care. Are we ready for that or not? Thank you.
Thank you, Dr. Hassan Hamid. Really, it was a wonderful talk on the paradigm shift in the synovial sarcoma management. And now we invite our panelists for the panel discussion on sarcoma. There our panelists include Professor Joseph Pressey, doctor and
Time differences. And we have Dr. Sadiq Mushtaq. He's with us, Dr. Ahmed Shaib, Dr. Ilyas Rafi, thankfully, because Dr. Ilyas Rafi is very busy these days with a very high profile patient in Shaukat Khanum. So thank you for coming here. And then Kashif, he had some burning issue and he had to leave. So I'll ask the participants and the audience to please ask these people whatever you want to know about sarcomas, and then we'll try to answer whatever you want to know. So my first question is, Dr. Hamid, you were talking about the adoptive T-cell therapy and the conditioning regime. So it is like we do autologous transplant, that we just cleans the patient's body with the cells so that they can host and then they can produce the.
new engineered T cell that we are giving back, they will be get a better chance to do the job.
Thank you. Oh, thank you. Dr. Joseph, can you hear us?
Yes, yes, good afternoon.
Thank you so much. Thank you for making it. And it was a wonderful talk. And we are having question answers. Any question from Prof. Presi?
Hi, Dr. Joseph. I'm Dr. Samir. I work in Shaukat Khanum. So I'm one of the medical oncologists and special interest in sarcoma. So my first question is, like you talked about using pazopanib. Definitely the data is an adult side, it's for the non-lipogenic sarcomas. So what about in I don't know, you've been seeing adult patients over there in your specialty, but the data like the last, I think in 2020, we had a paper like in pazopanib versus doxorubicin. So and it was non-inferior. So can you just tell us regarding these two drugs and what you use in your practice?
Yeah, no, good question. So certainly, the data for soft tissue sarcomas in general was encouraging based on that palette data that was published a few years ago. But in combination with chemotherapy, it doesn't seem to be provide any improved benefit. And that data was just published by Aaron Weiss and colleagues. And so I think as far as something that's going to be, moving forward in the future, probably limited benefit of pazopanib outside of, special indolent sarcomas and maybe desmoid tumors. The other thing is I would point out that olaratumumab plus doxorubicin also has been found to be of no additional benefit. So there probably is limited, movement forward with agents like that, unfortunately.
Thank you. So there's Dr. Elias. He's an orthopedic surgeon, and he wants to ask you a question.
Thank you very much, Prof, for joining us here in Lahore. It's very interesting talk you've given. I'm the orthopedic practicing orthopedic oncological surgeon here at Shaukat Khanum. I have a couple of questions. Now that we are here, we can have discussion on this. One is our traditional understanding about the bone sarcomas, especially osteosarcoma walls, that by the time they present to us, they have already metastasized, micrometastasized. And so you have to give the new adjuvant chemo. But now we're hearing from our colleagues, oncologists, that it is not as necessary to give the new adjuvant. This is one question. Should I go to the next question as well, or after this answer? Yeah, this is one question. The other question is that I think you answer. We talk about this question and we'll talk about the next question.
So the question is the value of neoadjuvant chemotherapy for osteosarcoma specifically? Yeah. Well, certainly we all agree that systemic chemotherapy is necessary for osteosarcoma, even in localized cases where we assume there are micrometastases in 80% of the cases. But the value of neoadjuvant chemotherapy specifically, I think, is pretty unclear. And I think if a tumor is resectable up front, we sometimes do find ourselves doing that still. So I think neoadjuvant chemotherapy in and of itself is not necessarily needed, but certainly systemic chemotherapy is absolutely needed for osteosarcoma. Let me maybe turn the question around to you. As an orthopedic oncologist, do you find that many of the osteosarcomas that you encounter could be resected up front?
Of course there are, but some of them are really downsized, and it makes a difference from an irresectable tumor to the resectable one. And before the start of the new adjuvant, we thought we would have to do the amputation. But after, when we review the chemo, and I thank to my colleagues here, the oncologists, then we are able to save the leg, and we go ahead with the limb preservation surgery rather than amputation. So it does help, of course, yeah. So,
Yeah,
so
I mean,
our focus would be more in towards of the new adjuvant as a surgeon on my side, like. Yeah.
Sure. And our standard is to give 2 cycles of MAP chemotherapy upfront as neoadjuvant therapy, and then we have the patient move to orthopedic oncology. There are some rare cases where we have had difficulty making a firm diagnosis with interventional radiology biopsies upfront, so with core biopsies, in which case we have pursued surgery up front to make a firm diagnosis. But in most cases, we're doing 2 cycles of MAP chemotherapy. Then the patient is moving to orthopedic oncology, and then 4 more cycles in adjuvant setting.
So we agree on the new adjuvant. Samir, you heard
Yes.
that? Yeah.
Yes. Is that a controversy on your side?
It's been a matter of discussion, like, yeah.
Okay. Yeah, we would agree. Two cycles of neoadjuvant chemotherapy should be standard of care.
Right. So the second question was, we did a review of the cases we've been doing here. So we're doing the oncology here for last more than 2 decades. So we thought we go through the last 1 decade and just to audit to see how many survival we have in osteosarcomas. And it was my senior resident here, he got it. It's about somewhere between 50 and 60, whereas in the literature, it's always more than 70 or at least 70. So we were wondering, could it be because, always blame the oncologist. We were wondering, could it be because they are using only the first line of the medicine oncology and not the second, third line? Maybe that was the. Of course, the presentations are late here and we get bigger size tumor. That's one reason. But on the oncological side, or the medical oncology point of view, what's your comments on that?
Well, I think if the question is, and I assume, and you can, your oncologist can fill me in, but I assume they're using standard MAP chemotherapy, methotrexate, cisplatin, doxorubicin, just like we are. So I doubt medically there is any major difference between what you're providing and what we're providing. And we wouldn't go to second or third line therapy unless somebody is relapsed. So I doubt it's a medical issue, but I'm speculating, of course.
The patient, they are the presenters.
Yeah, so-
Thank you very much.
Yeah. So I just want to clear one thing. So we asked, Dr. Ali asked to do upfront surgeries only when the limb is not salvageable, when the tumor is involving the joint or something like that. So otherwise we give 2 cycles of MAP in very selected patients who are very high risk, otherwise cisdoxo, followed by 4 cycles after surgery. So we have a very good collaboration. It was just a little thing.
Yeah, no, I wasn't doubting any of that. I think our approaches are very similar.
Yeah, thank you.
I just wanted to give the pediatric oncology perspective on that. So we looked at the pediatric oncology data for osteosarcoma over maybe 7 years, 8 years. And once we excluded the patients that abandoned treatment due to either refusal of surgery or for any other reason, our outcomes are actually 70% using standard 6 cycles of MAP, giving 2 neoadjuvant surgery, followed by 4 cycles post-operatively in the non-metastatic group, obviously. In metastatic, it's much lower. But when you isolate out the metastatic and we removed the abandonment group. So we have a large amount of abandonment. And if you include those, that's not really reflective of your therapy, I think. So in terms of the response to our treatment, we are at around 70% overall survival if we exclude the abandonment group. Just wanted to give the pediatric perspective on that.
Yeah,
And
that's
only if it's a fungating mass or it's infected, then and when it's now not going to be salvageable, then we prefer an upfront surgery so that it makes the delivery of chemotherapy easier, so that they don't have wound infections and so forth.
Yeah, that sounds like perfect state-of-the-art medicine.
So we have 10 more minutes and we'll take questions from Dr. Ali. Yeah, sure. Go
Can
ahead.
you give some insight into treating the use of using any targeted therapy in angiosarcomas and the related sarcomas, which are rare histologies, and obviously with time they are chemorefractory. So what is your experience using targeted therapies in these sarcomas?
So for angiosarcoma specifically? So certainly no, go ahead. I'm sorry. For angiosarcoma, certainly we do have some.
Specifically angiosarcomas.
Yeah, for angiosarcoma, we do have some experience using VEGF targeted agents, which obviously would make sense biologically, given what we know about angiosarcoma. We have seen some response from that, but with a patient with metastatic angiosarcoma, I have not seen anybody cured with targeted therapies. And so for angiosarcoma, I think we're still looking for novel agents and novel approaches. We talked a little bit about this in the pediatric session on Saturday. Certainly, there are certain subtypes of soft tissue sarcomas where unique treatment paradigms are emerging. I guess alveolar soft part sarcoma would be a great example of a tumor that responds to VEGF TKIs and PD-1 or PD-L1 inhibitors. And we've had a lot of success keeping those metastatic patients under control for years, even with those approaches. Epithelioid sarcoma, as I mentioned, with EZH2 inhibitors, there's some signal there. That's also a subtype where we've had some prolonged disease control with even drugs like pazopanib to discuss that again. And I have seen some success with PD-1 inhibitors there as well. I think and there was an excellent talk on synovial sarcoma earlier about immune approaches. That's one area where we're still trying to learn how to harness, how to use the immune system in sarcomas. We haven't seen a lot of success outside of undifferentiated pleomorphic sarcomas and some of the novel approaches to synovial sarcoma. But I think that probably could be a talk in and of itself, would be, unique subtypes of soft tissue sarcomas, given how many there are. But it is interesting. And I think it kind of goes back to the idea that we really need to be studying a lot of these subtypes individually, and it's hard to do basket trials or combined trials and to try to elicit a signal, given that it's very hard to power a study to do that properly.
Thank you. Yeah, Alina.
Yeah, I had a question for Dr. Emma Shoaib, and I guess Dr. Pressy can sort of chime in as well. So you mentioned indeterminate pulmonary nodules at diagnosis in osteosarcoma patients and how that's been associated with worse overall survival and event-free survival. And I think Dr. Rima is here, and she has published a paper from Shaukat Khanum, which has shown similar results, that it's actually, maybe those are not indeterminate and they are metastases. So, so you said your approach changes in terms of the type of prosthesis you're using. So I was interested in, can you elaborate a little bit more on that? And then Dr. Pressy, how do you deal with indeterminate pulmonary nodules when you get them in your patients?
Thank you. So essentially the question is that what I do and how indeterminate pulmonary nodule change practice. So if I have a patient who has indeterminate pulmonary nodule, I will try to replace the bone or the defect with metal on which patient can weight bear straight away. Less morbidity, better functional outcome. They go home quickly rather than spending with autograft, autoclaved bone and all that, which takes 6 months to 12 months to recover. So some of my colleagues say that I use mega prosthesis too much and I have used them a lot over the last 2 years. And I think Dr. Ilyas Rafi would second that we have seen much better functional outcome, quick recovery. So if somebody has got indeterminate pulmonary nodule, and if you look at the data, their survival is poor, you quickly do a quick surgery, better outcome, and send them home rather than getting them involved into a prolonged surgery with prolonged recovery and higher complication rate.
Okay.
So that's essentially how it changes my management.
Okay, thank you. Did you have anything to add to how you medically manage indeterminate pulmonary nodules, Dr. Pressy?
Yeah, I think we have been very aggressive with indeterminate nodules. And so for instance, let's focusing on osteosarcoma, we routinely do thoracotomies on our osteosarcoma patients, usually after cycle 3 and then after cycle 4. For left and then right thoracotomies to try to render the patient at least no evidence of disease. And so
we have used working with our thoracic surgeons. That's been a big part of our osteosarcoma strategy. Unless there's really too numerous to count nodules, but for a limited number, oligometastases in particular, we have been pretty aggressive. And our threshold has been about 4 millimeters for suspicion of metastasis. So for osteosarcoma, we've been fairly aggressive. And I think we're becoming more aggressive with soft tissue sarcomas as well. And so having a fairly low threshold to pursue thoracotomies, and then as consolidative therapy to offer whole lung irradiation in the setting of certain subtypes, so Ewing sarcoma and rhabdomyosarcoma specifically. So yeah, we've had Alina, we've had a pretty aggressive approach with indeterminate nodules, and even larger nodules where we've really tried to render the patients no evidence of disease surgically if possible.
That's really interesting. I don't think that's been our approach. We've been like kind of waiting till the end of therapy. If they're still there, we'll try to push them to get a thoracotomy done. But that's interesting to know. Thank you.
I was just going to say quickly, in this part of the United States, we have a lot of fungal disease, histoplasmosis, which sometimes can confuse the situation, and so that complicates things a bit. But again, we have taken on a very aggressive surgical approach, and I think our patients are benefiting from that.
I think we have the same problem over here, because speaking to my pulmonary colleagues, they also say because pulmonary tuberculosis is very common, nodular lungs are very common in Pakistan as well. So I think there has to be a balance, but these pleural lesions, 4 or 5 millimeter in size, they should be considered as metastasis and not as indeterminate, in my opinion.
Thanks, Professor. I think I'm Dr. Hamida. I'm consultant medical oncologist from the Christie Manchester. We'll also follow the same approach as well. And also with the neoadjuvant chemotherapy, you have an opportunity to monitor these lesions as well with an interval scan. So, and if they are proved to be metastatic, we go aggressive approach by doing a thoracotomy, but we do at the end of the treatment rather than cycle 4, cycle 6, which is also personal preference in this context.
I would just like to comment one comment, like especially regarding the indeterminate pulmonary nodules. Like Dr. Pressy has already said that, like examples of osteosarcoma and Ewing's and rhabdo. But overall, I think indeterminate pulmonary nodule, the main thing is just you need to see which type of sarcoma you are dealing with. So because, you know, the sarcomas have like there are 150 types of soft tissue sarcomas according to WHO, maybe there are more, and they behave totally differently. So again, I would say we cannot use this blanket term or like the blanket survival inference from only the indeterminate nodule. And I agree, like MHWave and we have been doing the surgeries and later on following the pulmonary nodules, really depending upon if that the disease is indolent, we at times, we just used to go for only surgeries rather than if they're increasing multiple, not for surgeries or any local therapy, we usually go for palliative chemotherapy as well. So I just wanted to make a comment.
Now the question is, for the indeterminate nodule, would you wait for it to get bigger or you start the chemo straight away?
So what we do, or like what our practice in Shaukat Khanum, like I got a fellowship in sarcoma where in Princess Margaret, the practice was the same, that we always used to see how the disease is behaving naturally. Like if it's aggressive, we will be aggressive as well. But I'm not saying that we're not going for thoracotomies or taking the nodules out, as Dr. Pressy has said. But having said that, I think the main problem over here at times is that the surgeons, especially taking out the nodules, we are not able to convince them to take the nodules out. And especially like if the disease-free period in between, it's around like maybe 6 months, then we have a very strong case to get a thoracotomy and metastectomy done. But again, maybe you're all welcome to comment on that.
There's another side of the coin as well, because the data said that 76% of those pulmonary nodules progress to show that they are metastasis, but they are 24% as well. So it was 1 in 4 patients who we thought that they are pulmonary nodules deemed to be metastatic are not metastatic. So if we adopt a blanket approach, then they get disadvantaged. I think in these contexts, we all go with the best approach, best treatment for that patient in that circumstances, knowing the caveats that you have some caveats here. We're going for the best modality treatment, but we will keep an eye on them. And I think if you are still more worried, you can delay the surgery after 3 to 4 cycles of fostromat. If there is serious concern radiologically that you don't feel comfortable that they look more convincingly metastatic, then you can delay your surgery to see how they evolve. If they disappear, then the conundrum is more challenging as well, isn't it?
Just to add, then we have local therapies as well for the lung nodules. If the patient is behaving well and the disease is in remission, then you can go for local ablative therapies in the form of RFA or radioablation.
Yeah, sure, these are available as well, but we are trying to describe a curative treatment pathway here.
Yeah.
And we are trying to deviate from the curative pathway based on some.
Thank you so much. One last question from Dr. Usman Hassan. Please come.
I am a histopathologist working at Shaukat, Khanum, and I have a very general question. Anybody can answer that. So I report sarcomas all the time, especially the margins. So nobody seems to be happy whenever a histopathologist reports margins. So what is the real clear margin distance if we talk about extremities, adult sarcomas, high-grade sarcomas? So I have read some meta-analysis, but various centers have various sort of protocols. So since there are many people here coming from different centers, so what is the minimum clear margins in case of extremities, adult sarcomas, high-grade sarcomas, leiomyosarcomas, MPNSTs, synovial sarcomas, and few more high-grade sarcomas?
Yes, the margins of resection is always been a matter of discussion. And there have been so many talks, so many things. But if you come to conclusion, what you do in practice, which I do, and my colleague here, Dr. Shoaib, would agree that when you are doing the resection, the safe resection, what is in my mind would be 2 centimeters for gross resection margins when we're doing the surgery with the eyes only. And when you go under the microscope, examine the tumor, I would say 5 millimeter would be a safe resection margin. Anything less than that would be less safe. But then even if it is 1 millimeter margin, somebody say, well, negative is negative, even if it's 1 millimeter. But I think 5 millimeter would be a safe one. Thank you.
We did several years earlier at Shaukat Khanum, we did a study where we all the indeterminate and larger nodules were removed. And what we found on histology was that out of total nodules which were less than 5 millimeter in size, half of them were malignant and 50% were benign. And those with size of 5 to 9 meter, 12 were malignant and 19 were benign. So this is what we found. I think this study was done about 5 to 6 years ago.
Thank you very much.
Can I ask a quick question from Dr. Pressy?
Dr. Pressy and Dr. Hamid, your take on the margin thing.
I'll just quickly say that that's a tricky question. And I always like to get the input of the surgeon too, especially if it's an orthopedic procedure, and get their intra-op observations and get a sense of how they feel about that margin. We have lots of discussion about individual patients. 5 millimeters is a great objective number, but we often work with less than that. Unless there's a clear margin, for instance, in osteosarcoma, post-op radiation would be fairly, rare to deliver here. So I think we have to be very convinced that it's truly a positive margin, and we'll accept as little as 1 or 2 millimeters, depending on what the orthopedic surgeon is telling us in terms of how he felt about the procedure. So we'll take as little as 1 or 2, depending on the circumstances. But 5 is a great number if you can get it.
Margins is always a contentious subject, and I said it also depends on how comfortable the surgeons are at the time of the operation, and also which site we are dealing with as well. And all these are numbers at the end of the day. So, but again, how we manage patients based on if we are worried about margin, then radiotherapy question arises to consolidate the management of those patients.
Tumor necrosis is less than 90% and you go for a higher margin, it will recur. There are more chances of recurrence. If you got a close margin, but there's a good tumor response of more than 90%, the recurrence will be low. So it's not a single thing which you can say, but do this margin, it will not recur. It has a multimodal recurrence regimen. So it all depends on how tumor behaves.
I think if I have to add onto this, I'm obviously a surgeon as well. So unfortunately, the size at presentation at our institute is so big that you always see the vessel draped over and being stretched by the tumor, almost always. So it's impossible to get 5 millimeter next to the vessel. I think I remember only 1 or 2 cases where the vessel was clearly away and we could say that this is away. Proximal tibia, you have got skin on the one side, so you cannot get 5 millimeter over there. That brings me to one of the tradition in Bedford Hospital, UK, where I used to work, where these samples used to be grossly examined in the presence of the surgeon by the pathologist. And they used to, the surgeons used to be there, the pathologists used to be there, and they would cut the gross specimen and they would explain that's where the sample came from. And that used to be very helpful because the surgeon could explain that that's where the vessel was and that's where the skin was, etc., etc. Although we orientated very well in Shaukat Khanum, but still from a histopathology perspective, it's very difficult to be absolutely sure that this is like, if you've got an area next to the vessel, you're never going to get more than a 1 to 2 millimeter margin over there.
I would like to comment, again, as Dr. Pesci has said, and I've been emphasizing as well, the type of sarcoma is very important. In DFSP, I think literature favors 3 centimeter margins. But again, that's a skin soft tissue tumor. And even 1 centimeter, between 1 to 3 centimeter, then you go for a post-operative radiation. So it really depends upon which type of sarcoma and again, the anatomical relations with the excision margins and all, they are very important.
Yeah, in surgery, we come across the situation every day. The tumor is close to the vessels. And if you want to save the vessel, you sacrifice the margin. And if you want a wide margin, you have to sacrifice the vessels, which means you sacrifice the limb as well. So with the help of obviously oncology and the radiation therapy, we are trending more towards saving the vessels and the limb, even if we are sure, even doing with the eyes only surgery, that margins are not going to be negative. So should we do that? Knowingly, during the surgery, the margins are going to be positive, but it's only, we're saving the leg, and we will depend on colleagues to do the chemo and radiation. Would that be a good approach?
Can I comment on that as well? Just for osteosarcoma, because we don't have radiation to consolidate with, I would never soft tissue sarcoma. Okay, yeah, not for osteosarcoma. Ewing's you can consolidate with radiation, but yeah. Okay, I just wanted to make sure, not for osteo.
I think patient have a say as well in this decision making, because we are fighting between limb salvage versus limb amputation, and And in the context of if you are looking for an R2 resection versus R1 resection, so this is a bit of a balance call between the two remain. I think with the AVINGs, definitely, because you're doing a lot of pre-op chemotherapy and even consolidation radiotherapy as well. So I think histology, have a say, patient should be a part of the decision making when you are making those tantalizing discussions when there's no right or wrong.
Margin of 1 millimeter and 5 millimeter and more than 5 meter. There is no difference of recurrence between more than 5 millimeter group and 1 to 5 millimeter group. But this is due to addition of radiations because we give radiation to both of these groups. So it's not only the margins, it's about the adjuvant treatment as well, which supported your treatment.
I think I'm a histopathologist at Shaukat Khanum. I would support both Ahmad Shoaib and Samir. I think it is very important if we want to improve the quality of care that some person from the surgical team should come to the pathology department and help us in the evaluation of the margins. What I have asked my resident is to omit the word tumor margin free from their dictionary, because I said that oncologists, we never know what is the standard of care, 5, 10, 15, 20, as Samir said, in some 3 centimeters is acceptable. So we just give the distance. But even when we say that it is positive, means when it is involving the ink resection margin, there are technical problems with seepage of ink and other things. So if someone from the surgery comes, I think that can be a great help to. And second thing which I have seen is that many times, previously the margins were positive and surgical specimens come to us after being margin positive. And I can't give you the exact figures, but I can tell you that majority of those tumors are actually, majority of those surgeries are actually tumor free. So that also raises the question that were they real margin positive or not?
Okay, in the interest of time, I think we'll close. And a special thank to Dr. Pressy and Alina both, because Alina lies with him. I never wanted you to wake up at 4 a.m. in the morning, and now I think it's 5:30 there. So a special thank, and we would love to see you next year, inshallah, in person.
Thank you. Delighted to join you. It's not too early. Thank you. Bye.
And thank you all. And it was really, really great honor to have you.